so that we can also complete in time.
Okay, just give me a minute. I'll just confirm about the from the tech team. And is Mrinmayi here? Can I get a yes?
Yes, I'm here.
Okay, cool. Yeah, so we can begin in 2 minutes, like by 4 5. We'll wait for a few more participants to join in until then.
Yeah, so let's begin. Sia? Yeah. Am I audible? And there's not a lot of background noises now because there's also some construction works going on. I'm really sorry for that. Yeah. So yeah, good evening everyone, and I am Priya Tiwari. I'm a second year medical student from Grand Medical College, Mumbai, and I welcome you all on behalf of GGMC R.I.S.E. So GGMC R.I.S.E. is the research and innovation club of our college, that is Grand Government Medical College, Mumbai, and I hope you know it very well. So yeah, and we are the journal club team of GGMC R.I.S.E. So what we do, in journal club we do the paper presentations and try to discuss the different types of papers in them, research papers in them. So let's begin. So our today's pre-session topic is how to read a research paper. So does anyone has any idea that what how to read a research paper? Have you read research papers before, or you do reading of research papers? You can answer in the chat section. A bit, okay. Okay, so yeah, let's begin how to do reading of research paper. So next slide. So, yeah. We all know this is the journal format of the research paper in which it is written. That is, title is mentioned, then the abstract, followed by introduction, method, discussion, conclusion, acknowledgements, and references. So this is the format in which a research paper is written. But this is not the format in which we will read the research paper. There is a different way of reading a research paper so that we can gain the maximum knowledge from it. Next slide. So yeah, before starting the reading of the research paper, you have to check the date of publication, author's name, their affiliated organization, and journal in which they're published. So over here, towards your left, is the paper which is going to get presented today in our journal club session further later in this session. So yeah, first of all, you have to check the date of publication. So over here, April 1, 2021 is the date of publication. So why is it important to check the date of publication? Because recent researches are more preferred. Why? Because in medical field, we know that there is continuous advancements made and learning about the new researches is really important. And then the author's name and their affiliated organization to check the authenticity of the paper, and then the journal in which it is published. So it's really important that we read the research papers from well-known journals. This is also that this is because we know that the content which is provided is authentic, because many of the journals publish the papers just for the sake of making money, and we are reading paper for the knowledge purpose. So yeah, over here the journal in which it is published is the Lancet, and it is a very well-known journal. And apart from this, if you want to know what are the well-known journals, then you can read PubMed and Index Journal. They are mostly authentic journals only. Next slide. So yeah, now the step one that you are going to start the reading paper. So the step one is you have to read the title. So why the title? Because you have to read and understand the title, because it gives the conclusion of the study. It summarizes what the research is about. You'll get the idea what exactly topic of the research is and what researchers find out. It may also include the type of study, many a times population of the study, and in which geographical area it took place. So over here, safety and immunogenicity of inactivated poliovirus vaccines, schedules for the post-eradication era, a randomized open label trial, multi-center phase 3 non-inferiority trial. This is the title of the trial. So it states that it is about the poliovirus vaccine in the post-eradication era, and it also states the type of the study, that is, it is a randomized open label trial. So you'll get the idea what the topic of the paper is. Next slide. Then you'll read the abstract of the paper. So why abstract? Because abstract is the summary of the paper. It defines the aim of the study, it highlights the main topics of the study, gives information about the major findings, and results are mentioned. So when you're doing the literature search for your own paper, and at that time you will read the title and abstract, and then select the paper if the paper lies in your criteria and you want to use the paper in your research for referencing. Next slide. Now, this is the step 3, that is skimming through the paper. So after that, you have read the title, you have read the abstract and understood what the paper is all about. You choose the paper that this is the paper I want to read further. And then for reading, you choose the paper for reading. And then while reading, this is the first reading that you will do, that you will roughly skim over the paper. You have the general idea of the paper. So in this, you will read the introduction completely, major headings and subheadings of the paper. Check the pattern of the paper, read the conclusion. You can go through the graphs and charts and you can underline the known words and unknown words, then try to understand the vocabulary used. And this reading is not done to completely understand the paper, what paper was exactly about, and what methodology and results and conclusion, etc., is obtained, but to have a general idea about the paper. And this should take 5 to 10 minutes of your time. So this is what you were supposed to do. This is what we asked you to do before coming to this session for the paper presentation also. So I would like to ask a question over here. How many of you have read the paper, today's this paper, which is going to get presented, which we asked you to do? You can answer in the chat section. None of you have read and come. We asked you to do a homework. Okay, no issues. Okay, Pratham has read. Nice, Pratham. Okay, you didn't. Okay. Atharva has read partially. Okay, it's okay. It's okay even if you haven't read the paper. But whenever you are asked to read a paper for a journal prep session, in the further sessions also, you have to do this step. That is the step 3 you will follow. That is skimming through the paper. Next slide. Yeah, research papers are big, Atharva. And it also takes a lot of your time to read them.
It's not audible.
Hello, yes. Yeah, we are looking into it. It seems Priya is facing some network issues. We request you to wait for a minute. Yeah, she just rejoined.
I'm sorry, I had some network issues. So am I audible?
Yeah, audible now.
Yeah. I'm really sorry for the technical issues here. So yeah. So this is this after skimming through the paper and having done the first reading, this is the next step which you have to follow, which is step 4. You have to read the introduction. So if you are a beginner and reading the research paper, you're not familiar with the topic already, then you have to read the entire introduction section completely. And if necessary, you also have to read the cited references. Now, while reading cited references, also you have to do the first reading. That is, you have to skim through the you have to understand the information, familiar with it. And if you're familiar with the topics, you have already done a lot of reading in that particular topic. So you can just you can just jump to the last paragraph of the introduction, and this gives the basic message of the study. Next slide. Now here comes the step 5, which is you have to read the results and conclusion section. Now, if you'll see in a research paper, after introduction, methodology section is mentioned, but you will not read methodology, that is methods and material section. After introduction, you will directly jump to the results section. So why you not read the methods, that I'll tell you in the end, but now you have to read the results section and conclusion section first. So after having a general idea about the paper and reading the introduction, now you'll read the results, which where you have to read the entire text and trace back to the figures which are mentioned. You have to examine the graphs and the figures yourself, understand the graphs and the figures, and then you have to interpret the graphs and figures on your own and draw the conclusions on your own, that why this result was obtained and what kind of conclusion you will get from this. And then you will read the conclusion and compare the conclusion which author has written from the conclusion that you have drawn yourself. So yeah, here over here you can see the graphs which are mentioned in the results section. Next slide. Yeah. Now you'll go through the discussion section. You'll read the discussion section entirely, and you will see that do you agree with the conclusions and the things which are which author has written, and do you agree with them, and do you think that experiments and the things which can be done at your this can be done at your own level, or is there any research gap you can find over here, and any additional experiments and things that can be done. This is also the place where you can see the research gap and you can draw your own research question out of it, and then what are the limitations of the study and what are the future aspects of the study. You will also read that section. Next. So yeah, here is the step 7, which is here is the step 7, that is you will go through the methods and material section now. So why methods and materials section I have kept in the end? Because if you are reading a research paper just for the knowledge, know what this research is all about. So you do not have to go in depth in this section, because you are not going to do your own research at this point of time. So the methods and materials section is important when you want to carry your own research, and if you are randomized control trial, example.
Sorry to interrupt.
Do
Priya, your voice
off
seems
and
to break in between. Maybe you can try switching off your camera
okay,
and speak again.
okay, yeah, yeah.
No, actually, couldn't hear clearly yet.
Am I audible now?
Yes, now better.
Yeah. I'll repeat this slide or the previous slide also. Yeah. So this is the step 7, which is the methods and materials section. So you will read this methods and materials section in the end. Why? Because if you are reading the research paper for your own knowledge, you are not supposed to be part of this section, and only if you want to carry your own research and you want to understand this new technique, you will read this methods and materials section with a deeper knowledge, deeper understanding, and you'll dig out what kind of methods were used and why it was used for this kind of study and stuff. So yeah, next slide. Yeah, and here is the step 8. Actually, it is not the step 8 which you will do in the end, but this is the step which you will do since the beginning of while reading the paper. This is the taking notes. It's really important that to take notes, because it improves your comprehension and helps you remember the key points. Reading a research paper is not like reading a newspaper or a novel where you read and then you can forget after a day or two. If you're reading a research paper, you have to like keep that knowledge in your memory at least for like for 1 month or two minimum, but yeah, as long as you can. So yeah, taking notes really helps when you want to revise the paper again. And this is also a really important step when you're doing a literature review, literature search, and while writing a review paper or for citing the references for your own paper. This is a really important step, so that because again and again you have to go back to that research paper. So you have to do this part. And while taking notes, how can you take notes? You can, if you don't want to write a separate entire thing in a separate notebook, you can highlight the keywords and the important sentences in the PDF itself which you have of the paper. So yeah, this is really important step of note taking. Next part. Yeah. So yeah, here is a doubt which Devanshu have. Since we'll be reading the papers in Chrome or any other browser, is there any highlighted tool extension for Chrome or any other separate app for iPad? So yeah, I don't have any idea about the like if Chrome has something of highlighter or something, but you can there's a hack which I follow, that I take the screenshots and then I highlight it from my gallery tool, which is whichever is available in my phone itself. So yeah, I would request tech team if you have any input to give. uh, 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 all of you, those who have doubts, you can put in the chat section. I'll address them in the end. Yeah. Now, so that we know how do we read a research paper for understanding purpose and for the paper presentations like such, where we want to have the brief idea about the topic. So I told you that the first reading that you'll do, that is skimming through the paper, takes you 5 to 10 minutes. But the second reading and in-depth reading, which you will do, takes about an hour and so, maybe 1 hour or 2 hours, which is minimum, and maximum to maximum you can take 4 to 5 hours, because you have to understand each and every term in the paper and you have to apply that knowledge further. So yeah, this is the minimum time which requires for reading a paper entirely. Now let us learn what RCTs, that is randomized controlled trials, are all about. So this is the randomized control trial is one of the paper which we have chosen to present you in the presentation part. So hence it is important to have a basic idea what RCT is all about. Next slide. Hello. Yeah. So RCTs are the experimental or interventional studies which are done. It is a study design in which the groups are divided into two groups, which is one is the experimental group and the other group is the control group. So why is it done? I'll tell you subsequently. But first of all, let us learn where the RCT stands on an evidence pyramid. So RCT stands on the one of the top levels in evidence pyramid, and it lies just below the systematic review and meta-analysis. And it is considered as a gold standard in evidence-based pyramids and evidence-based medicines, because this is something which can be done and whose results can be is most reliable results which are obtained if done properly. So yeah, this involves allocating the subjects randomly into the experimental and control groups. So why is it important random allocate the experimental and control group? Hence the name suggests randomization. Does anyone know the answer of this? It is also mentioned in the PPT, but let me check your presence of mind. Can anyone answer why randomization is important in RCT?
It decreases the bias.
Yeah, it does decrease the bias. Thanks so much. So yeah, to overcome the biases when the samples are compared, we adopt the method of randomization while allocating the subjects into the group, and this also ensures the descriptive characteristics which are distributed randomly among the two groups. Next slide. Yeah. Now let us see what is the flow or the design of the RCT when it is carried out. So first of all, before starting an RCT, you have to have a clear planning of how are you going to conduct your uh, entire clinical trial, and you have to get the ethical approval for your experiment or clinical trial that you're doing. Next, you have to select the sample or the subjects for your suitable population, or the subjects for your trial. So for this, you will categorize the population based on your inclusion or exclusion criteria, and then you will group them into the suitable sample. Now, for this, you will place the individuals of similar sex into the same group, so that we get the best outcome. Because if something like for the medicine oral hypoglycemics that we want to measure, so yeah, okay. So something like oral hypoglycemics that we have taken and we want to test them into a population. So maybe it may give some other results in the younger population and some other results in the older population. Hence, a population of similar age group and similar sex and other ethnicity, etc., have to be grouped together for this. And then After selecting the suitable sample size and according to the inclusion and exclusion criteria you have defined them, you will now randomize them. That is into the two groups, experimental groups and the control group. Now, what experimental group is? That experimental group will get the suppose you are doing a drug trial. So for the drug trial, experimental group will get the drug, which is the new drug, which is the interventional drug. You have to test whether the drug is working properly or not, or what kind of outcomes the drug gives. So that drug will be given to the experimental group, and the control group will get the drug which is already known to us, whose effects and outcomes we know already, and or the placebo. If we are comparing our study the drug with the placebo, you'll give the placebo to the control group. And after this step, you will do the manipulation, follow-up, and assessment. Now, the most important step that you do in RCT is randomization. So yeah, just remember the randomization is the most important step. Next slide. Now let us see what are the strengths and weaknesses of randomized trials. Next slide. Yeah. So randomized trial is the only type of study which is able to establish the causation. It has the ability to assign and administer treatment or intervention in a precise controlled way, because we have the control that what kind of drug we are giving at what time, in which period of time, and for how much long we are for how much long time we want to give that drug, or when we have to stop that drug. And then it decreases the selection biases and minimizes confounding. That is effect of other factors which occurs due to the unequal distribution of the chosen population. As I said you earlier, that the similar age group is placed together, so that the effects which we would have got because of unequal age distribution, that was eliminated. This is one of the strengths. Then the measurements can be chosen precisely, making it easier to make observation consistently. Now, the most important step is blinding is easier. That helps to improve credibility. So here, I would like to ask you all: do you know what blinding exactly is, and why is it done? Okay, no one. So yeah, blinding is done in various type of researches, and RCT is one of them. So what is blinding? Blinding can be of two types. That is single blinding and double blinding. So in single blinding, the patient doesn't know that he or she is getting the experimental drug or the control group drug, that the drug which is already known. And then when in double blinding, the patient and the investigator both don't know that this kind of person, this person is getting experimental drug or the control drug. So why blinding is important? Because it helps to improve the credibility of the research, and also to remove the biases again. Because if we know that this person is diseased and we are not supposed to give he or she the experimental drug, but because he is diseased and we know that he is diseased, we will not give him the experimental drug and we'll try to give him the control drug. So yeah, blinding hence helps us to remove the biases of the study too. Then you can make the trial large. One of the major strengths of RCT is that it can be carried out on large scale, and the results which are obtained are very trustable. You can trust the results, and one of the most important thing at our level when where we want to publish our own papers and stuff, is that a successful RCT with conclusive and inconclusive result is eminently publishable. So yeah, next slide. Now let us learn about the weaknesses. So yeah, what are the weaknesses or some of the drawbacks of RCT is that it is high cost, because it has to be carried out on a large scale. It does require a high amount of cost, increased time, because you have to contribute a lot of your time, and over a period of time you have to test the drugs which you're giving. Then logistically it's challenging because it's carried out again on a large scale. Then results may not always mimic the real life treatment situation, and risk of choosing treatment or subject whose consent is not valid, or unethical treatment is also involved. And then the knowledge translation into the clinical practice does not always occur, because although it is a randomized trial, but it is done in a controlled way. So yeah, it is not necessary that whatever result was obtained in our RCT is applicable in clinical practice too. So yeah, here this was the brief idea about the RCT. I hope you understood at least some bit of it. Thank you so much, and I would request my batchmate Mrinmayi to continue with the paper presentation. Thank you so much. And I'll answer your doubt towards the end of the session after the paper presentation. So I hope it's clear. Mrinmayi, you can continue. Hello. Yeah.
Okay, am I audible?
Yes, yes. You can begin.
Okay. So good evening, everyone. I'm Mrinmayi. I'm a second year MBBS student at Grand Government Medical College. And today I'll be presenting the paper Safety and Immunogenicity of Inactivated Polio Vaccine Schedules for the Post-Eradication Era, a randomized open-label multi-center phase 3 non-inferiority trial. Now, before we proceed further with the paper presentation, there are a few terms that you should be aware of in order to understand this paper. Next. Hello. Okay. So, an open label trial is a type of clinical trial in which the information is not withheld from the trial participant. So, it means both the researchers and the participants know which treatment is being administered to them. Now, moving to non-inferiority trial, the aim of non-inferiority trial is to show that the new treatment is not inferior to the existing one. That means it is either equally effective or better than the existing treatment. To understand non-inferiority trial a little better, let's take an example. So suppose there is a trial designed to compare the effectiveness of new antibiotic with the existing antibiotic. So in order to compare these two antibiotics, we can construct three possible hypotheses. So for the first hypothesis, the new antibiotic must be at least as good as the existing one, which means the new treatment must be as good as the existing one, but it can also be better than the existing one. So to put it in mathematical terms, the effectiveness of new antibiotic is greater than or equal to the effectiveness of old antibiotic. So this is which means the new treatment is not inferior to the existing one. For the second hypothesis, the new antibiotic must be better than the existing one, which means the new treatment can no longer be equivalent to the old treatment. It must be better than it or superior than it. This means superiority comparison. The last hypothesis indicates that the new antibiotic cannot be worse than or better than the old antibiotic, which means both the new treatment and old treatment are equivalent to each other. Next slide, Sneha. So I hope you all understood the terms related to this paper. So we can begin with the actual presentation. So for the control and eradication of poliovirus, the preferred vaccines were travelent oral polio vaccine, which is a live attenuated type of vaccine, and it contains all three virus serotypes. And along with this, a travelent injectable polio vaccine, which is an inactivated type of vaccine, was also used in some high-income countries. But following the global eradication of wild poliovirus type 2, the WHO Strategic Advisory Group of Experts recommended that live type 2 polio vaccine should be withdrawn from all uses. So the trivalent OPV was replaced with bivalent OPV. And they also recommended inclusion of at least one dose of injectable polio vaccine in a routine infant schedules. But following the cessation of type 2 OPV use, there was a rising number of vaccine-derived poliovirus type 2 outbreaks were reported. So this elevated the importance of injectable polio vaccine dose as the only source of immunity against the polio type 2 virus. But due to the supply and cost constraints associated with the IPV use, WHO recommended the introduction of alternative IPV vaccination schedules, including the use of fractional doses instead of full doses of IPV. The potential global withdrawal of all OPV following the eradication of all wild wild-type polioviruses will necessitate increased use of injectable polio vaccines or fractional injectable polio vaccines as the sole source of immunity against polioviruses. Next slide. So the aim of this study was to compare the immune responses to intramuscular full-dose IPV with intradermal fractional IPV in two different schedules in poliovirus naive infants in Panama and the Dominican Republic, where there have been no wild poliovirus or detectable circulating vaccine-derived polioviruses transmission since 2001 outbreak. Next slide. This trial was a randomized open-label non-inferiority trial, and it started on 23rd October 2017 and lasted till 13th November 2018. For this trial, healthy 6-week-old infants with no signs of febrile illness or known allergy to vaccine components from Panama and Dominican Republic were chosen. The infants with previous polio vaccination, known case of HIV infections, or the infants with blood disorders contraindicating intramuscular or intradermal injections, or in case any household contacts had been vaccinated with oral polio vaccine in previous 4 weeks were excluded from this trial. Next slide. So 4 groups were made based on 4 vaccination schedules, and the groups were 3 IPV dose group, 2 IPV dose group, 3 fractional IPV dose group, and 2 fractional IPV dose group. After enrollment, the infants were randomly assigned into one of these 4 groups using a computer-generated block randomization. As this is an open-label study, the administrator, nurses giving the vaccine, and the infants and their parents or guardians were not masked to the treatment allocation, which means they were aware of the group or treatment they're allocated. But the laboratory personnel responsible for measuring the immunogenicity were masked, which means they were not aware of the treatment groups or the time points. Next slide.
Sorry to interrupt. Can I ask a question to the participants meanwhile? Because we have just learned about RCTs, and the previous speaker had mentioned about 2 types of randomization. So what kind of masking, like this masking is similar to which kind of randomization mentioned earlier? Would anyone like to mention that? Okay, Mrinmayi, you can, yeah, but which kind of, which one was done in this paper? You can see the blinding. Okay, I'll mention single and double blinding. Yeah, thank you. Okay, Mrinmayi, you can move on. Thank you for like letting me ask this question.
Okay, no problem. So for this study, Salk injectable polio vaccine, which is an inactivated type of vaccine, was used. For the full dose IPV groups, the dose was 0.5 ml, the route of administration was intramuscular, and the injection site was anterolateral aspect of thigh. Whereas for the fractional IPV group, the dose was 0.1 ml, the route of administration was intradermal, and the injection site was upper arm. So moving on to the study design. For both the 3 dose groups, the vaccination schedule was 10, 14, 36 weeks, which means the first dose was administered at 10th week of age, the second dose was administered at 14th week, and the third dose was administered at 36th week. Similarly, for the second 2 dose regimens, the doses were administered at 14th and 36th week of age. All the infants were monitored for 30 minutes after vaccination in order to check for any immediate adverse reactions. And the parents were asked to record solicited local reactions like pain, redness, induration at the site of injection, and body temperature for the next 7 days. During the period of trial, 4 blood samples were taken from each participant. The first blood sample was taken before administration of first vaccine, which means in the three dose groups, the first blood sample was taken at 10th week of age, and for the 2 dose groups, the blood sample was taken at 14th week of age. At the end of this trial, all the infants in the 2 dose groups were given an additional 1 or 2 doses of IPV in order to complete the recommended dose schedule or complete their vaccination. The immune responses in this trial were expressed as seroconversion rates. So seroconversion rate means the total proportion of each group that changed from seronegative to seropositive, or from baseline seropositive infants who showed at 4-fold or higher increase in their antibody titers. Next slide. Okay, for this study, the comparisons of neutralizing antibody titers between regimens at the same time point were done using geometric mean titer ratios, facilitated by an analysis of covariance model of log to titer to adjust the baseline concentration and the study site as fixed effects. The superiority comparisons of seroconversion rates were made using one-sided Fisher exacts test. All the non-inferiority comparisons of seroconversion rates between vaccine regimens and vaccine types were made with the lower bound of two-sided score-based confidence interval with a 10% non-inferiority margin. So to understand what a non-inferiority margin is, let's go back to the previous example which we took for understanding the non-inferiority comparison. So non-inferiority margin means that the new antibiotic can be less effective up to 10% as compared to the old antibiotic, and it will still be considered as non-inferior. So which means the non-inferiority margin is 10%. The non-inferiority margin was chosen via fixed margin method. Next slide. For this trial, a total of 785 infants were screened, out of which 12 were ineligible. So 773 infants were randomized into 4 groups. The 3 IPV group was allocated with 2 infants. 2 IPV group was allocated with 178 infants. Similarly, 178 infants were allocated to 3 fractional IPV group, and 217 infants were allocated to 2 fractional IPV dose group. But throughout the duration of trial, few of the parents withdrew their consent. Few discontinued due to death and protocol violation. So at the end of trial, in the per protocol population, 178 infants were included from the 3 IPV group. 159 infants were included in the 2 IPV group. 160 infants were included in the 3 fractional IPV group, and 195 infants were included in the 2 fractional IPV group. Next slide. So this table reports the baseline characteristics and demographics of the safety population. Now, what safety population indicates is the number of infants who have received at least 1 dose of vaccine. So, as you can see in this table, the baseline characteristics and demographics include the number of girls and boys in each group, mean age of the infants, mean weight of the infants, and as well as their ethnicity. Baseline seropositivity rates were mentioned before administration of first vaccine. That means 10th week of age for the 3-dose regimens and 14th week of age for the 2-dose regimens. So as you all can see in this table, the seropositivity rates at the 10th week were higher as compared to the seropositivity rates at 14th week. So this decrease in seropositivity rates indicates the progressive decay of maternal antibodies. Next slide. Okay, so this table shows the seroconversion rates at the end of the trial, that is at the end of 40 weeks. So once again, I'll explain what seroconversion rate is. So seroconversion rate represents the total proportion of each group that changed from seronegative to seropositive. So as you all can see, the 3 IPV group, which is marked with red circle, shows 100% seropositivity for all 3 poliovirus types, which means all the infants in this group showed seroconversion at the end of the trial for all 3 polioviruses. Now, when we compare the 3 fractional IPV group with 2 fractional IPV group, the ones which are marked with blue circle, the seroconversion rates for poliovirus 1 and poliovirus 2 are almost similar in both the groups. But when we compare the seroconversion rates for poliovirus 3, the seroconversion rates in 2 fractional IPV group are significantly lower as compared to the 3 fractional IPV group. So keep this in mind. We'll revisit this table at the time of discussion again. Okay. So this table shows the superiority and non-inferiority comparisons between the per protocol population of each vaccine schedule group. So in the non-inferiority comparisons, when you look at the 2 fractional IPV group versus 2 IPV group, the first one, it showed non-inferiority for poliovirus type 1 and poliovirus type 2. Similarly, the 2 fractional IPV group versus 3 fractional IPV group showed non-inferiority for poliovirus type 1 and poliovirus type 2. But when we look at the 2 IPV group versus 3 IPV group, which is marked with black circle, it showed non-inferiority for all 3 virus types. And the rest of the non-inferiority comparisons were exploratory and they were not significant. Now moving on to superiority comparisons, when we compare the 2 IPV group with 3 IPV group after 2 doses, which means all the infants were administered same amount of doses, that is two doses. But the 2 IPV group showed greater seroconversion or superiority. So can we go back to the previous table? As you can see, if we compare the 3 IPV group at 18 weeks, which means after 2 doses, whereas the 2 IPV group after 2 doses, the seroconversion rates in the 2 IPV group are significantly higher than the seroconversion rates in 3 IPV group. Similarly, you can see seroconversion rates of 3 fractional IPV group compared with 2 fractional IPV group are significantly lower, which means the seroconversion rates not only depend on the number of doses, but also the age of infant at the time of administration. Next slide. Okay, so these graphs show geometric. Okay, so these graphs show geometric mean titers of serum neutralizing antibodies for poliovirus type 1, 2, 3, respectively, plotted against the age of infants at the time of sampling. Okay. So if you can see in the 3 IPV group and 3 fractional IPV group, in the 3 IPV group and the 3 fractional IPV group, that is the purple and green bars, the antibody titers progressively increase throughout the clinical trial and they reach peak at the 40 weeks. Now in 2 dose regimens, that is the red and the blue bars, the titers decrease by 36th week. That is after administration of first dose. But following the second dose, the antibody titer type 1 and 2 increase such that the 3 fractional IPV group and 2 IPV group, that is the green and the blue bars, showed almost similar mean titers at 40 weeks. So as you can see, for the poliovirus type 1 and 2, the green and blue bars are almost at the same level at the end of the trial. The highest geometric mean titers to poliovirus type 1 and 2 were reported in 2 IPV group at end of 40 weeks. That is the red bar. It showed highest antibody titers for poliovirus type 1 and 2. But for poliovirus type 3, the highest titers were reported in 3 IPV group. That is the purple bar at the end of 40 weeks. So I hope it's clear for all of you. Next slide. Okay. So the parameters used for safety evaluation were serious adverse events and medically important events. So a serious adverse event is any untoward medical occurrence, whether it is considered to be related to the study vaccine or not, at any dose which can either result in death or is a life-threatening or requires inpatient hospitalization or prolongation of existing hospitalization, or results in persistent or significant disability, or is a congenital abnormality. So all of these are considered as serious adverse events. So in this study, no reaction within 30 minutes of vaccination no adverse reaction within 30 minutes of vaccination were observed. One infant in the 3 IPV group died because of shock and cardiorespiratory arrest, but this was not considered to be causally associated with the study. When we combine the local adverse events for all 4 of the groups, a total of 15 cases of pain, 26 cases of redness, and 4 cases of inflammation were all reported. But none of the serious adverse events or important medical events were considered to be causally associated with the vaccination. Next slide. So moving on to the discussion part, when two intradermal fractional IPV doses can elicit strong immune responses, which is non-inferior to full dose IPV, but the response is dependent on the age of the infant at the time of administration. When administered at 14 and 36 weeks, significant seroconversion rates were observed, whereas when alternative schedules were when vaccines are administered at alternative time or alternative schedules, the seroconversion rates were significantly lower. Similar studies in Bangladesh and India tested for alternative schedules, and the seroconversion rates were significantly lower. Can we go back to the third table? No, after that. Okay, so compared to the 3 IPV group after 2 dose and 2 IPV group after 2 dose, which means in the 2 IPV dose group, we administered the vaccine at 14th and 36th week of age. And in the 3 IPV group, we administered the first 2 doses at 10th and 14th week, which means higher seroconversion rates were observed when the vaccine was administered in a delayed schedule, that is at 14th and 36th week of age as compared to the 10th and 14th week of age. Similarly, same results were obtained when fractional IPV was used. Can we go back to the discussion slide? However, 3-dose fractional IPV regimen might be considered more ideal given the suboptimal immunogenicity and lower geometric mean titers overall associated with overall 2-dose fractional IPV. Can we go back to the table? Okay, so as we have highlighted here with yellow color, when 3 fractional IPV group produced higher titers for the poliovirus type 3 as compared to the 2 fractional IPV group. So in order to obtain a better immunity for against all 3 poliovirus types, 3 fractional IPV might be considered a more ideal option. Now, so in accordance with the SAGE recommendations for future 2-dose regimens, this study reports that the delaying of first dose until the 14th week of age to minimize interference by maternally derived antibodies. Near universal immune response can be elicited with 2 full-dose intramuscular IPV when given in delayed schedules reported in this study, implying substantial cost and supply savings. Can we go back to the tables? Yeah. So as you can see, when two IPV group, the seroconversion rates were almost similar to the 3 IPV group for all three poliovirus types, which means with administration of 2 IPV doses, we can achieve near universal immunity against all three poliovirus types. And because we are using less number of doses, there will be cost. The cost will be minimal, and okay, can we go back to the discussion slide? Now, this trial confirms that the administration of injectable polio vaccine alone or in combination with diphtheria, tetanus, pertussis-based vaccines is safe. So, as we saw before, there were no severe adverse event associated with the administration of vaccine, other than temporary minor local reactions like pain, redness, or induration. Next slide. So to conclude this paper, the observation suggests that the adequate immunity against poliovirus type 1 and type 2 is provided by 2 doses of either IPV or fractional IPV at 14 and 36 week of age, and broad immunity is provided with 3 doses of fractional IPV, enabling a substantial savings in cost and supply. So I guess we have reached the end of presentation. Thank you for your patience. If anybody has any doubts, you can ask, unmute yourself or put it in the chat box.
Hello, Sneha. Can I take the questions which are already there in the chat box?
Yes, please go ahead.
Yeah. So the first question, which was asked by Devanshu, that what are the inclusion and exclusion criteria? I hope while the presentation, you must have come across this criteria that what were the eligible participants. We took the participants which were healthy, which were 6-week-old infants, and no signs of febrile illness or known allergy to the vaccine components were there. So we included only the infants which were 6 week old and 6 week old. So yeah, we included only the participants which fall into this criteria, and apart from this, we excluded the infants which had received previous polio vaccination or had HIV infection or any blood disorder contraindicating intramuscular or intradermal injections, and any household contacts of the OPV vaccine. So this is what the inclusion and exclusion criteria is, that we define a set of criteria, uh, inclusion criteria, that we define a set of criteria, and if the participants fulfill that criteria, we'll include them. And there is a set of exclusion criteria, and if the participant has that criteria, we'll exclude them from the experiment. So I hope it's clear now. And then the second question you asked was, can we do RCTs at MBBS level? You can do RCTs at MBBS level, but it's more or less difficult to do, and it's a lot challenging to do RCTs at MBBS level, because again it has to be done on a large scale so that your results are trustable. If you select only 100 subjects for your experiment, it is not a reliable result. Results are not that reliable and not applicable on a larger scale. So you have to do it on large scale. It's high cost and high. You have to put a lot of time. So it's really difficult to do RCT at college level. But yes, you can do RCTs at MBBS level. You can include experimentation, like you are at MBBS level, you will not try a new drug which is there in the market. You'll not try the experimental drug, but obviously you can try something like nutritional supplements. You can give the experimental group the nutritional supplements maybe, and the control group the already existing drug in that way. So yeah, you can do, but yeah, it's challenging to do at MBBS level. uh, yeah, thank you so much. I hope all your doubts are cleared. Any other doubts that you guys have, you can put in the chat section now itself also.
Also, we would welcome any feedback or any recommendations or any ideas to like for a journal club session to improve the interactivity or anything that comes to your mind. Thank you, Ritik, for the feedback. Yeah, before you all start leaving, we would like to take a group picture and then maybe we can end if there's no more doubts. Please switch on your cameras for the group picture. That's what I meant when I asked. Like, let's take a group picture before you all start leaving.